Friends by the University of MacroPro. I am Diane Cohen, and it is my pleasure to bring to you these programs, and today to bring to you Angie, June, and a whole menagerie of new friends for me. Angie, how are you? And could you introduce our friends?
Absolutely. Thank you so much, Diane, for inviting us again. And I think some of you guys may be familiar with me. Diane and I have participated in several of these webinars, and it's good to be back. I do have Christy that is going to be actually the presenter for this session. And Christy is a dynamic presenter and is one of a brilliant case manager and a supervisor. I got Amy here and Mackenzie here as well. I'm going to let Amy introduce the rest of the team.
Yeah, okay. Well, we got a little bit of business to do before we do that. And one of the things, Angie, I know that you're bilingual. Can you tell everybody what language you speak?
Kim, can you take a guess? I do speak Cantonese. Pretty good about with Mandarin as well, and so I do that.
So, our question for our audience today, if you would put it into the question box, is: are you bilingual, trilingual? Actually, my mother spoke eight languages, and I have a sister that speaks 10, and I can hardly speak English. So, I don't know how that works. But if you speak more than one language, would you put that in? Oh, Cindy says nope, she doesn't. Magna says she speaks Spanish. Sarah says she tries to be
I'm trying.
bilingual. Yeah. So, oh, good. You guys keep it up. Let's look at those. So, the reason I'm asking is, Mackenzie, I think you have some exciting news about some
Yes.
bilingual speakers.
So we just hired three more case managers today, two of them being bilingual. They speak Spanish. We know that that's really important. So that's something that we look for in our case managers.
Well, that's exciting, to be able to bring in nurses that can really speak the person's language. So that is exciting. Okay, ladies,
Definitely.
and let's keep that going, audience. We'd love to see if you guys are bilingual. I see some of you put it in there, and it is very fun to see. Valerie speaks Spanglish, and I understand very well. Chelsea says, "No, I wish." I know. Now's the time for us to learn. All right, I'm going to do a bit of housekeeping, and then I'll be turning it over to Amy. So today's webinar is worth 1 CEU. You must be logged on, which you are. Your certificate will arrive in approximately 1 hour. You have 30 days to let me know if you have an issue with that. Make sure that you check your emails, your spam, etc., because a lot of people say, I didn't get it, but they found it in their spam. So be sure to do that as well. There are handouts, so make sure to download those so that you have the reference material in the future, because this is a really important topic, and all of us want to have information on spine. The thing about this is it's not only good to know for injured workers, but it's always interesting for us to know because we always have backaches and creaks and such like that. So download those. And then if you have any questions, Mackenzie and Amy are going to be asking those questions at the very end. So put those questions into the question box and we will address that at the end. And then, of course, you can always watch this again on the Macro Pro YouTube channel. So I'm going to turn this over to Amy at this point.
Thank you. Thank you for having us here. ISYS, I represent ISYS Case Management. I am the Customer Relations Coordinator in Northern California. I also cover Northern Nevada. Mackenzie is our Southern California rep, and she's also the southern portion of Nevada. I wanted to introduce Christy. She's been an absolute pleasure to work with. She has over 15 years of experience in the healthcare industry. She joined ISYS in 2016 and currently serves as one of our supervisors for the case management team. Christy is also very involved in training and mentoring new case managers, as well as with customer and regulatory compliance. She has a wealth of knowledge about case management, complex and catastrophic injuries, trauma care, neurological and orthopedic injuries, and pain management, and sometimes has been known to take a text from me with a weird question. She's awesome to deal with. So enjoy.
Thank you so much, Amy, and thank you everyone for joining today. Today we are actually going to cover spinal cord injuries and the different types of injuries and management. When many people hear the term spinal cord injury, they immediately think about the life-changing limitations of what someone cannot do. However, one of the most important things to understand is that individuals with spinal cord injuries can and do lead productive and fulfilling lives, often remaining fairly active. So the images on this slide represent just a few examples of the many ways that people continue to participate in work, recreation, athletics, and arts following a spinal cord injury. Many individuals return to work, pursue new careers, or even continue their education with appropriate accommodations and support. So advances in assistive technology, adaptive equipment, and workplace modifications have significantly expanded opportunities for independence and vocational success. We can see here from these photos examples of a few different people. Someone who's adapted to learning how to paint with using a paintbrush in their mouth, someone who is working with adaptive equipment, and even multiple sports and performances that are also using adaptive equipment. So today, our main objectives, and we're gonna cover a lot today. And ultimately, this is a huge, robust topic, and we're not gonna be able to cover everything about spinal cord injuries, but we're gonna give you a general overview, and we'll trigger, where do you wanna learn more? What kind of more specific topics do you wanna learn about when it comes to spinal cord injuries? There's a lot of resources, support, and research for spinal cord injuries, and this is a field that is constantly evolving and changing. So we're going to start by defining spinal cord injury. We're going to review basic spine anatomy and the related functions. We're going to discuss current treatment and sequelae of spinal cord injuries, and then review claims implications associated with spinal cord injuries. So first of all, what is a spinal cord injury? Ultimately, it's an insult to the spinal cord resulting in a change, either temporary or permanent, in its normal motor, sensory, or autonomic functions. There's two main types, traumatic and non-traumatic spinal cord injuries. The spinal cord does not have to be severed to have a spinal cord injury. And some injuries may have complete recovery, while some will essentially result in complete paralysis. So in non-traumatic spinal cord injuries, these are caused by non-accident related factors such as spinal stenosis, tumor compression, vascular ischemia. Anything that happens in the body that it can affect the signaling of the spinal cord can be a non-traumatic spinal cord injury. Traumatic spinal cord injuries are most of what we see and what we deal with. It's caused by external forces such as accidents, falls, sports injuries, gunshot wounds. A person can break their back or their neck and yet not sustain a spinal cord injury. If only the bones around the spinal cord or the vertebrae are damaged, but the spinal cord is not affected. In those situations, the individual may not experience paralysis after the bones are stabilized. So a few statistics here. The 2025 population size in the United States was estimated to be about 342 million people. The most recent annual incidence of traumatic spinal cord injury is approximately 54 cases per million in the population. This equals about 18,000 new traumatic spinal cord injury cases each year. This does not include those who die at the location of the accident. Currently, approximately 300,000 people live in the United States with a spinal cord injury. 90% of these types of injuries are due to trauma, with 37% being motor vehicle accidents, 32% being falls, 15% being violence such as gunshot wounds. 8% sports and recreation, 4% medical surgical, and 4% other. The average age at the time of injury is 44, and 78% of new cases are male. Can you take a guess why there's more men than women who are injured? Essentially, it's risky activities. They're more likely to participate in activities that could lead to a spinal cord injury, especially when it comes to like sports and recreation. Other causes of spinal cord injuries can be vascular disorders, tumors, infectious conditions. As we talked about, most of these are due to trauma, but it can be a non-traumatic cause also. Mortality rates are significantly higher during the first year after injury, particularly for severely injured persons. Luckily, life expectancies continue to increase due to advances in technology and education and support. So the average lifetime cost for a high level injury, this is a C1 to C4 injury, so in the neck, with an age of injury of 25 is estimated to be about $3.5 million. The average acute hospital stay is significantly improved these days, down to 19 days, with an average rehabilitation stay of 37 days. This, compared to the 1970s, has greatly improved. Back then, they spent about 30 days in acute and 110 days in rehabilitation. The leading causes of death for spinal cord injury patients is respiratory issues, pneumonia, influenza, pulmonary embolism, septicemia, especially for those that have high-level injuries that the respiratory system is affected. So to really understand spinal cord injuries, we need to understand the anatomy of the spine, because once we know the anatomy of the spine, we can essentially predict often the types of impairments that a person will have and the different systems of the body that will be affected. So when we're looking at the spine, we know, right, it holds you up, it protects your spinal nerves, it connects your ribs. The natural curvature of the spine is like a letter S, which enables the vertebral column to absorb the shocks of movement, such as walking, running, and jumping. We're born with 33 vertebrae, and by the time that we reach adulthood, 24 of those vertebrae basically remain. The sacrum and the coccyx fuse together in adulthood. We can see here, looking at the spinal nerves, we have the vertebral body, we have a nerve root, we have that spinal cord. Your spinal cord is about the width of your index finger. And we have the main cord that basically shoots out into 13 peripheral nerve roots. Starting from the top, the neck has 7 cervical vertebrae referred to as C1 to C7. The cervical region allows flexion, extension, bending, and turning of the head. The vertebrae here are smaller than the other vertebrae, which allows for a greater amount of movement. Next, we have the thoracic spine, the chest or upper back, where there are 12 vertebrae in the thoracic region referred to as T1 to T12. The motion here is fairly limited, and this is due to the thoracic spine actually attaches to the ribs, which prevents a whole lot of movement side to side. The lumbar region, referred to as L1 to L5, accounts for the low back area. In most cases, there are 5 vertebrae in this region. For reasons unknown, sometimes adults are seen with a 6th vertebrae. The main motions of the lumbar spine, of course, is bending forward and extending backwards with the low back. This is the region where most back pain is felt, as it supports the major weight of the upper body. Below this, we can see the sacrum and the coccyx regions at birth. It's composed of 5 vertebrae, S1 to S5, and the coccyx is composed of 3 separate vertebrae, but these do become fused. The coccyx, also commonly known as the tailbone. So if you've ever bruised your tailbone, you know how badly that can hurt. The sacrum and coccyx provide very little movement, but the sacrum does form the joints with each of the hip bones and helps to stabilize the pelvis. And then, of course, we have additional protection on top of that with muscles and other tendons and soft tissue structures. So when we start talking about the type of paralysis here, where the level of injury is really dictates how much impairment somebody has. Quadriplegia, you may have also heard the name tetraplegia. It is the same thing, just different root words. Quadri is Latin and tetra is from Greek. So for this, the injury above the first thoracic vertebrae results in quadriplegia. And this involves paralysis of all 4 limbs and affects the abdominal and chest muscle walls, leading to breathing issues. For paraplegia, this is injury below the first thoracic spine, and they may have full use of their arms and hands, and then paralysis of the legs and abdomen up to the nipple line. So we look here, that first one there is a C4 injury, and we can see the areas in red are indicating areas of paralysis. So for a C4 injury, they would have complete paralysis below the neck. For a C6 injury, it would result in paralysis of the hands and arms as well as the lower body. For a T6 injury, this would result in paralysis below the chest. And for the L1 injury, it would result in paralysis below the waist. So information travels along spinal nerves below the level of injury, and these will either be completely or partially cut off from the brain. And this is where the signaling essentially ends. The body is still sending and receiving messages, but it's blocked by the damage of the cord injury, but not the unaffected part of the cord. So when we talk about for cervical injuries, levels C5 to 7 is the most common. Thoracic level injuries are in general less common because of the protection by the rib cage. For the lower spine, T10 to L2 is the most common for those areas. So we have different types of injury. We have a complete spinal cord injury, which this is absence of sensory and motor functions in the lowest sacral segments, but you can also have an incomplete spinal cord injury. This is a term used to describe the partial damage to the spinal cord. With an incomplete lesion, some motor and sensory function may remain. It's important to note that with an incomplete spinal cord injury, these are completely different from person to person. They may have feeling but little to no movement. Others may have movement with little to no feeling, essentially. Incomplete spinal injuries differ from person to person because the damage is different. So for example, in Brown-Séquard syndrome, there's damage towards one side of the spinal cord, resulting in impairment or movement to the injured side, but pain and temperature sensation may still be preserved. The opposite side of the injury will have normal movement because that area of the spinal cord is not impaired. So a spinal cord injury can be sustained through different mechanisms. Of course, destruction from direct trauma, compression by bone fragments, foreign objects such as bullets, bleeding, hematoma, or disc material. There can be impingement on the spinal arteries. It's important to note that spinal cord injuries can develop slowly through weakness, poor coordination, or paralysis, especially if you think about if this is being caused by swelling in the area, this can come on relatively slowly. Spinal shock is temporary swelling from trauma. Spinal concussion can be from violent jolts to the cord. Spinal contusion is actual bruising of the cord. These things can indicate more of a temporary injury versus a permanent injury. We're talking about paresthesia. This is abnormal sensations such as burning or tingling. And then in myelopathy, injury to the cord may cause tightness in the muscle tone, cause hyperreflexia, coordination problems, weakness, and numbness. So when you talk about the types of paralysis, the most common is actually incomplete quadriplegia, with about 47% of spinal cord injuries being that type. And paraplegia complete is about 20%, paraplegia incomplete also about 20%, and then quadriplegia with a complete is only about 12%. We can also see via this picture here that you can have hemiplegia, like we talked about, where if the injury is to one side or the other, only one side may be affected. So who does this affect? Who's the primary payer for these types of injuries? Private insurance does account for about 50%, with Medicaid about 27%, Medicare 8%, work comp only about 7%, self-pay about 2%, and other about 6%. So the initial treatment is critical in this type of injury. The time between injury and treatment is critical and can significantly influence both the extent of complication and the degree of recovery. It is critical to immobilize the spine right away in any injuries that we have suspected spinal cord injury or fractures. This prevents further injury to the cord at the scene of the injury. So maybe a brace, a collar, a halo. The next most important thing is to establish a patent or airway. So depending on the level of injury, as we discussed, the patient may not be able to breathe on their own or may have impaired respiration. So it's of course very important to make sure and establish an airway as early as possible. Next, steroid drugs can be used to minimize cell damage, and surgery may be necessary to remove foreign objects. If it's safe, it won't reverse damage to the spinal cord ultimately. But if you guys can put in the chat here, what do you think is pictured here in this image? What do you think we're seeing here on this MRI? If you guessed a bullet, you are correct. And unfortunately, it is lodged right centrally there. So for diagnosis, the first thing to do is assess and assume a spine fracture until proven otherwise. This may consist of x-rays, a CT scan, MRI. I want to show you this image before we move on though. You can see here in this image where the arrow is, this is actually a fractured and dislocated cervical spine. The second image here that we're looking at, you can see that dark dot there where the arrow is actually a spinal cord tumor that is compressing the spine. So we are seeing both a traumatic and non-traumatic spinal cord injury here. So beyond our imaging, we also may do myelograms, nerve conduction studies, neurological evaluation. All of these can be used to inform not only the level of injury, the severity of the injury, and guide future treatment. So, of course, everybody's worried about spinal cord injuries and their outcome. One of the most important things to consider is there are many other complications of spinal cord injury outside of the initial injury. Other medical considerations can include pulmonary complications. As we've discussed, the respiratory system can be impaired, especially anything above C5 is at risk. They may have to be on a ventilator, and there's serious questions regarding will they be able to breathe on their own later. Deep vein thrombosis, DVT, in paralyzed limbs, blood does not flow normally, and any limb that is inactive for a long period of time can be very prone to blood clots, pulmonary embolism, thrombus. The patients are on blood thinners, so there's definite concern with like prolonged bleeding and surgical considerations. Spasticity and contracture are also another major consideration. Even though somebody may not be able to move their limb upon command, that muscle may still have tone, and prolonged muscle contracture or spasticity can lead to deformity. If the limb maintains that tone for a long time, this can lead to permanent shortening of muscles and connective tissue, and severe spasticity can become disabling on its own and lead to further deformity. So part of the considerations in rehab is not only learning how to manage the various limbs, but also to help prevent them from becoming more disabled over time due to these contractures or shortening. As you can imagine, just positioning of different limbs can be very concerning or difficult if it is contracted in a position that is keeping you from, say, being comfortable or using a wheelchair. However, some patients can definitely benefit from a small amount of spasticity because it can help maintain muscle bulk, and it can help assist them with transfer and help support standing programs and ultimately improve circulation. Heterotropic ossification is abnormal deposits of bone in the muscle and tendons as a result of our body's attempts to heal an injury, leading to calcium deposits in that area. This can cause swelling and deformity in joints, long bones, and redness. You can see autonomic dysreflexia is listed here. This is a medical emergency. We're going to go into this in further detail in a few minutes. But the part of the vertebrate nervous system that regulates involuntary actions, such as your intestines, your heart, your glands, and is divided into your sympathetic and parasympathetic nervous system. When this is impaired, you may have things such as no sweat. You might also have hyperhidrosis, which is excessive sweating, which is very common in upper cord level injuries. And this can affect somebody socially and emotionally. It can be very embarrassing. In addition to that, we have cardiovascular considerations. When the autonomic nervous system is disrupted, you may have very low blood pressure and low body temperature, hypothermia. So steps to manage this will be part of the care plan. Pressure injuries or pressure ulcers are very, very easy to come by in these patients. Anytime prolonged sitting or lying in a wheelchair or a bed can lead to pressure ulcers, poor cushioning. And because there's loss of pain sensation, they may not even realize that an injury is occurring. So this is one of the most important considerations, not only for early treatment, but for extended treatment too, is making sure that we're rotating them frequently, that they have proper cushioning, that they are moving and shifting, even manually, to prevent that breakdown. Because we talked about having less blood flow and less circulation to these areas, it makes it even easier for these injuries to happen due to poor circulation. And when you have poor circulation, you have poor healing, delayed healing, and it can be very difficult to manage. The best thing to do is prevent these types of injuries to happen, because once they get started, they are very difficult to manage. And just complications from these, I've seen even leading up to death, essentially, from injuries that got very out of control. Neurogenic pain, having a pain program, having a pain plan. Some patients have an extraordinary amount of pain depending on the injury and the type of nerve pain that they have. So that would be part of a treatment plan. Bowel and bladder control. Many injuries are not able to maintain their own bowel and bladder control. A bowel and bladder training program is very important. We will see when we start talking about the autonomic dysreflexia a little bit later, how critical this is. But essentially, they're at a much higher risk for urinary tract infections and issues due to bowel and bladder problems. When your spinal cord signals and urges for a person to go when it's full, a person without a spinal cord injury, obviously you feel this, you know this, but the spinal cord injury, if it is interrupting that signaling, they're not going to be able to feel that they're full and they need to go. So you have to be very intentional about managing this, or it can cause even greater effects. Talking about osteopenia, this is when there is a bone density that is lower than normal, but it's not severely low. Osteoporosis is significant bone loss resulting in weak, fragile bones that fracture easily. The greatest bone loss occurs below the level of injury. After spinal cord injuries, the body actually removes bone faster than it replaces it. Bones need weight bearing to stay strong. Why is this dangerous? After spinal cord injury, people can sustain fractures from minor traumas. Think while transferring, twisting during repositioning. And because sensation is impaired, they may not even immediately know that a fracture has occurred. And then let's talk a little bit about sexual dysfunction. For males, they may have varied sexual effects, and they may have reduced fertility. When someone experiences sexual thoughts or arousal, that signal travels from the brain down the spinal cord to the nerves that control the penis. Those nerves cause the blood vessels to dilate, increasing blood flow and producing an erection. People may not know, but there's actually two different forms of erections. Psychogenic erections, which are caused by thoughts, emotions, visual stimuli, fantasies. Reflexogenic erections are caused by physical touch or stimulation. Why is this important? Well, in living life after after injury, it's important to also maintain sexual intimacy and relationships. And wouldn't you know it, but different types of spinal cord injuries may have different type of impairments when it comes to erections. So for injuries above T11 to T12, they may not be able to have thought-induced erections, but touch-induced erections are generally easier, while injuries below T11 to T12 may preserve psychogenic erections, but have impaired reflex or touch-induced erections. So the exact outcome depends on the level and the completeness of injury, and this is important information in learning what sex looks like after injury. For females, they may not have a menstrual cycle for 3 to 6 months after the injury, but they may still be fertile. Changes in sensation may be apparent, but they still may be able to achieve orgasm, pregnancy, and more amazingly, natural delivery. You may not know that, but actually women with spinal cord injuries, the body is a miraculous thing and may be able to even have a natural delivery. So the key takeaway here is that sexual function is altered, but not necessarily lost, and learning how to adapt. Patients may be able to have full and fulfilling sexual relationships, experience pleasure, maintain intimacy, and may even be able to have children, although adaptations may be needed depending on the level of injury. So in autonomic dysreflexia, this is a medical emergency. This is caused by overactivity of the nervous system, and if not treated, they can go into coma, cardiac arrest, stroke, or death. So any of these symptoms, it is important for them to seek medical treatment right away. The symptoms here are a pounding headache, excessively high blood pressure, think 200/10, very high. A slow pulse of around less than 60 per minute, a flushed face, cold, clammy skin below the level of injury, sweating above the level of injury, goose pimples, blotching of the skin, nausea, nasal stuffiness. All of these are major warning signs, and in conjunction, it is a medical emergency and they need to seek medical treatment. Why does this happen? It can happen because of an overfull bladder, UTI, a blocked urinary catheter, an overfull bowel, gallstones such as stomach ulcers, etc., pressure injuries, infections, extreme temperature changes, sexual activity, even pregnancy. So this happens with irritating stimuli below the level of cord injury, such as an overfull bladder. The stimulus sends nerve impulses to the spinal cord where they travel upward until they are blocked by the level of injury. Because they cannot reach the brain, this sets off a reflex that activates the sympathetic portion of the autonomic nervous system, and it results in spasms and narrowing of the blood vessels, which cause that rise in blood pressure. So if you notice the top 3 causes here, what is it, right? They're all involving the bladder or the bowel. So this is why having a bowel management program is so critical and so important, because if your body isn't appropriately, well, it's signaling, but you're not receiving the signal that you need to use the restroom, you need to have timed and scheduled evacuations to make sure that you avoid this emergency. So in rehabilitation, they're learning about mobility, right? They're in physical therapy, occupational therapy, learning how to use mobility aids, learning how to transfer, and essentially be prepared to live life at home after discharge. May involve a respiratory team, a pulmonologist. And again, we want to relieve or prevent contractures or spasticity that may involve further impairment or further difficulty. We want to maintain the highest level of function that the person is able to achieve. And then we want to control the symptoms of hypotension, hypothermia, and address any cardiovascular or kidney management needs. Additionally, weight control is super important. As the upper body and Well, depending on the level of paralysis and the level of function that they have, weight control is super important to just keep the person as mobile as possible, keep their function as high as possible, and also to prevent secondary things that come with significant weight gain, such as diabetes. And then in rehab, they're also learning to prevent the autonomic dysreflexia, like we talked about. So part of this plan also would be medication management, pain management, and controlling and learning to live with that nerve pain. We talked about the bowel and bladder management programs, and then also learning with the specific type of injury that the person has, how to basically continue to have rewarding sexual and intimate relationships, and teaching the family and the patient how to live after spinal cord injury. In addition to this, it's absolutely essential that they have appropriate psychological counseling and support groups. One great thing that has come out of the internet age as well is even just the online support groups, as well as the in-person support groups, and just the knowledge that is available these days. I follow a couple of creators that are on YouTube that are post spinal cord injury. Actually, both the ones that I follow primarily were post-traumatic spinal cord injuries, and just really being aware and spreading awareness to what life looks like afterwards, both for those of us who may have our lives touched by spinal cord injury, but also for the general public to learn what life is like on the other side. When we start getting into psychosocial concerns, of course, depression, isolation, altered self-image, and altered self-esteem may come out of this kind of injury because of role changes, right? And loss of potentially being the breadwinner, loss of being able to participate in their preferred recreation, sexual changes, financial burden. So it's very important to not only get the person to the highest level of function that's possible, but also that they're able to participate in the things that they care about in their life as well. So, and then family and patient education, something that can be very frustrating is the person, right, who's trying to learn to live and function as independently as possible, with also a family that's wanting to help them, at the highest point possible. That can be a difficult and challenging line to walk. So I really wanted to share here too a story of an injured worker that I had as a rush case working as a case manager with ISYS. Framing perspectives is incredibly important in any serious injury, but especially in a spinal cord injury. I had this injured worker who he was actually injured. He was a semi-truck driver, and he was on the highway driving. It was following a snowstorm, and he was driving next to a snowplow, and something happened. And unfortunately, the snowplow driver hit a button and deployed this snowplow blade. The snowplow came into his lane and it flipped the truck. Essentially, it was a terrible, terrible injury. He was care flighted to the hospital, and I came on scene for the first time as he was actually having spinal surgery. And I met with his wife, introduced myself, and I came back after he was out of surgery and actually met with the injured worker who had just received the information that he may never walk again, and that ultimately they didn't know the significance or the seriousness of his injury and what his ultimate outcome would be. And of course, he was terribly distraught and crying. And, what was he supposed to do with the rest of his life? He was a very active person. He loved to hike. He was very involved in his kids' lives. He was coaching one of the kids' teams. And, he pretty much saw this as the end of his whole future. And while I didn't promise anything, I told him, and we talked about that his number one job right now was his recovery and participating in his recovery to the best of his ability. That we weren't going to go to the dark place yet, and we weren't going to sit in the what ifs and essentially write off the rest of his life. This is one of my favorite stories, because not only did he walk again, but he was actually able to return to a near full duty job with his same employer. So he was one of the lucky cases that, due to extreme swelling and trauma to the area, he was paralyzed. But over the course of weeks and months, he did have function return, and he was ultimately able to regain function. He would text me saying that he had walked another 2 miles that day. You know, once he started having sensation coming back into his limbs, he was able to progress quite quickly, you know, and it can mean the difference between somebody who is really engaged in their therapy and in their recovery program versus somebody who, you know, kind of writes themselves off really early on. So he did end up having to have multiple level fusions of his spine, and ultimately he was able to return to work as a truck driver. He was a long haul truck driver before, where he would have to chain up essentially, and his physician did not want him regularly lifting and dragging around those chains. And so they ended up actually changing his job, where he became a local truck driver, where it actually had the effect that he was home every night with his family, which actually ended up being a blessing for him. They just didn't want him chaining anymore, so he wasn't doing the long haul truck driving anymore, but he was able to stay with his same company and return to full duty with the exception of no chaining. So, you know, we went from a case where he was told that he may never walk again to within a year, he was back to work full duty. So while not all paralysis is temporary, some cases are, and a positive outlook, active engagement in recovery, and positive self-talk, and focusing on what they can do instead of what they cannot do is just an important function of recovery. And this can help to maximize their function and ultimately their satisfaction in their lives. We're not denying the changes that spinal cord injuries bring, but by shaping perspectives, we can embolden injured workers to also make the most of their recovery. And this is just an important kind of note for any serious injury, in addition to spinal cord injuries. So when we talk about getting them back into community reintegration, we want to get them to resuming the pre-injury activities they found joy in both their home and in their community. This can be recreational activities, connecting with spinal cord injury populations and group support, and getting them access to resources. Here we can see in this picture that this gentleman is able to enjoy a nice beach day with his family. Unless you've ever been in a wheelchair, you can't really imagine how limiting that can be, and how the most simple things can become so challenging and difficult access. Things like a curb that would have never stopped somebody before can derail, honestly, a whole day. So, but there are so much adaptive equipment out there now, like this. It's an off-road wheelchair that can handle being out in the sand. They even have off-road wheelchairs nowadays where people can do things like hunting. My husband has a group that is actually known for taking out people who have hunting dreams in their adaptive equipment, because these things are very expensive. But this group actually takes people out so they can participate and use, essentially, more so like rent these devices to fulfill some of their dreams. So there is a lot that has come a long way to help people really enjoy their previous hobbies. And when we're talking return to work, of course, ADA accommodations, job site evaluation, and potentially vocational retraining, especially if their job was very physical, they may not be able to return to anywhere close to full duty, but that doesn't mean that they can't have fulfilling lives and actually find jobs that will work with their level of injury. So prognosis. It depends greatly on the level of injury and the severity and the damage to the lesion. It depends on if they have a complete or an incomplete spinal cord injury. And it depends on if they have any other post-injury complications or medical conditions. Unfortunately, post-injury complications can significantly worsen outcome and limit function. So it's incredibly important that these things are limited by appropriate management and escalation of care as necessary. So it also matters how old were they at the time of injury, and did they have any significant comorbidities prior to injury? And amazingly, 20% of traumatic spinal cord injuries are employed 1 year after injury. So the most notable improvements that we see are between 1 week and 6 months, but they may continue to improve within that first year. And if they make it that first year, if they survive the first year, they are likely to make it the next 10 years. About 75 to 85% of people survive an additional 10 years. So where 3% of patients die during acute hospitalization, only 10 to 20% of patients who have sustained a spinal cord injury don't survive to reach acute hospitalization. So if they make it through that acute hospitalization, they have a pretty good outcome. As far as future medical care, these are lifelong injuries that need lifelong management and unfortunately have lifelong expenses tied to that. But we do have computer assisted technologies, we have prosthesis, we have tons of things that can improve mobility and functionality. They're going to need a lifetime of medical supplies, durable medical equipment, medication, bowel and bladder supplies, especially if they're having to catheterize themselves multiple times a day. Those are going to add up over time and should be accounted for. Lifelong medical visits, therapy, caregivers, potentially equipment replacement and repairs. Nothing lasts forever. They may need home modifications. You'd be surprised to know how many things you can't reach or can't access in your home if you can't stand. They also may need transportation or vehicle modifications, and ultimately they may even need a long-term care facility. This is primarily if they are ventilator dependent and are never able to essentially breathe on their own. So, but the future for spinal cord injury survivors is bright. We actually have a lot of research and clinical trials currently going on. We have approval to begin human safety testing on stem cell treatment. With stem cells, this focuses on repairing tissue damage and restoring function to improve each patient's quality of life. Patients are treated by injecting stem cells into the cerebral spinal fluid, which flows within the spinal canal. With bionics and robotics, this is also very exciting. For centuries, people who had paralysis were limited and resigned to using wheelchairs, but that's no longer the case. We have things such as exoskeletons that can help people to walk again. You heard that. They can actually help patients walk again. So the Johns Hopkins University has also been using brain implants via thought control to move robotic prosthetic arms. We still have a long way to go, but it is happening. And VR, or virtual reality, is the use of technology such as a head-mounted display, HDM, a tracking system, a sound device to create an interactive three-dimensional experience. Virtual reality can be considered a promising tool for rehabilitation of many different neurological disorders, including patients with both motor and cognitive deficits following a spinal cord injury. It's also being tested to reduce neuropathic pain. So claims, what are the claims implications for a traumatic spinal cord injury? As you see, spinal cord injuries are complex and very involved. Early and appropriate intervention is absolutely critical towards sustained outcomes. The first is to determine the extent of injury, what other systems are involved, what's the nature of the injury, what's the level of the spinal cord injury, is it complete or incomplete? Next is to ensure treatment is at an appropriate facility. It is so important to mention that not all rehabilitation centers are appropriate for a spinal cord injury patient. It is absolutely essential that they are receiving treatment at a center where spinal cord injuries are. It's very intentional that they're doing it. You don't want them receiving treatment at somewhere that is not used to treating spinal cord injuries. And then you want to determine the length of stay and, is early transfer to acute rehabilitation possible? And there should be an immediate referral to nurse case management. Because spinal cord injuries are a lifelong claims management issue, it's absolutely imperative for early case management referral for cost containment, coordination. Spinal cord injury services are very complex. It's not a single occurrence claim, and management is lifelong. We want to make sure that they're getting appropriate treatment from the very beginning of their injury all the way through and throughout their life. Their conditions and needs will change as they age. So what can case management do for you? Case managers are experienced in spinal cord injuries and rehabilitation. Initially expect high case management hours. It's very intensive work initially on this kind of case. There is a ton of coordination. They're likely making daily hospital visits and contact, providing support to the family, helping to determine the extent of the injury, and coordinating any changes of condition, any changes to the treatment plan, and finding appropriate referral of services or facilities for rehabilitation. There is life after a spinal cord injury, and it can be very productive, but it really depends on how the injury is managed. So the case manager will establish contact with the family, the healthcare team, and the employer, which is critical. We talked about daily hospital visits, family support, education, and participation in family conferences is important. The family should also be on board with the injured worker and understanding not only the treatment plan, but the progression of recovery as well. The case manager can help to determine appropriateness of the rehabilitation services and referrals, as well as any medical equipment that may be needed. And as we talked about, home and vehicle modifications or needs. They can also help to conduct a home safety assessment and, help decide what's the appropriate discharge plan. Can they be managed at home versus do they need permanent placement? Most of the permanent placements are due to ventilator use, where they're not able to breathe on their own. Do they have strong or weak family support? Do we need additional home health, or is the family able to manage the needs? And then to help establish reentry into community, school, work, and recreational activities. And it's important to mention that helping to find allocation of different financial resources, there are many, many things and grants and studies and that are available out there, but you may have to dig, you may have to look for it. Just because something may not be covered under, like, say, workers' compensation, or it may be experimental in nature, doesn't mean that they may not be a good candidate for those things. So we can also help find additional alternative resources available to them. And then determining lifelong long-term care needs and prevention of secondary injury and complications. As discussed, it's absolutely essential that the injured worker know how to manage their injury, know the warning signs, so they can seek emergency treatment later on if necessary. But prevention of secondary injuries and things from blood clots and contracted limbs and are all important, because without those things, they can unfortunately suffer worse outcomes. So, and then life care planning. As we discussed, this is a lifelong injury, and they're likely going to need lifelong care and resources. This can be very helpful and absolutely essential for claims purposes to prepare for what that looks like. So the key takeaways here are that there's multiple complexities in any spinal cord injury. We need appropriate providers, we need appropriate facilities. We need proactive prevention, and to set high reserves very early. Set them higher than you think that you may need. Case management intervention can really make the difference on the outcomes, of whether they are independent or dependent. Thank you, everybody. I think I have some friends who have been monitoring the chat for your questions. I would like to open it up to those because we still have a few more minutes that we can kind of dive into any questions that you might have. Oh, you're muted, Diane.
There we go. Let's bring your coworkers back on and see if we have any questions. That was really fascinating. There was a lot of information being disseminated. Things that I think a lot of us don't think about, you know, just everyday care.
Yeah.
All right. So do we have any questions, ladies?
I don't think there is any.
All right. Well, there weren't any questions. We're going to give people just a moment to be able to put a question into the chat. But I will say, I want to thank you very much for your presentation. It was excellent. There was a lot of things that, you know, a lot of times we know about injuries to the spine, but we don't think about some of the exciting things that are happening, like the exoskeleton, you know, to be able to have somebody stand again and take care of the family. The story that you shared that, you know, the man was very active and didn't want to write himself off. And it's so great to see that. You do see more and more of those stories. And so I certainly hope that that's going to be the case in the future, that we'll see more and more people recover from that. Do we know if stem cell, Jerry Heyer has a question, I think, ladies, if you want to look for that. So do we know if stem cell research helps at all with these spinal cord injuries?
Yes, and actually by placing the spinal cord, or sorry, the stem cell in that area, they can have regeneration of all different kinds of tissues. So not only with spinal cord injury, but many, many different kinds of injuries can respond positively to stem cell research. I know we're in the early stages, but it is something that's already showing a whole lot of promise in these kind of injuries. And whether or not we're talking the difference between improvement of symptoms and reduction of pain and, you know, some rehabilitation versus complete potential, you know, I don't want to say recovery, but, you know, massive improvements. I think we're only gonna see with time, but it's definitely something that's very, very interesting as we're going on. And I didn't cover it in particular. I mean, if we could just even dive down into medical equipment, even just the ability for now some of these wheelchairs to be able to go from a sit to stand is such a difference in being able to even just stand in your own home and be able to reach something versus bringing everything down to a level that is accessible. It's not, especially if you are in a space limited home, may not be a good option, but there's so much different adaptive equipment out there. It's really a great time to be learning about these things and continuing to watch recovery.
That's exciting. All right, ladies, do we have a question?
Looks like Olivia says, are they using stem cell therapy on patients with complete spinal cord injuries?
Oh, interesting.
It's in the research stages, so I know that there are different programs that are doing it, but as far as with a complete, I don't know that you can ever kind of recover fully from a complete injury, but I do think that stem cell research is probably one of the most promising because you can regenerate your own tissues.
That's good.
Any others?
Jamie added, she said, not a question, but thank you for all the information. Her husband works on and does modifications on complex wheelchairs for Kaiser, and he sees all the improvements they have firsthand. And she says, I really appreciate the whole process from A to Z. Thank you. So
absolutely.
Thank you for sharing.
All right. Well, ladies, I want to thank you so very much for joining me today. Today was the 8th of 10 of the University of MacroPro Summer School Series. We have 2 left. And so if you haven't signed up for the other 2 classes, please do. You can go to macropro.com and see what those are. Until then, I want to thank you all for joining us.
Sorry.
Okay.
Edward asked, red light therapy for spinal cord injuries. Is that a thing?
You know, I'm not familiar with red light therapy specifically for spinal cord injuries, but I do know that it's been shown to improve conditions in a lot of different types of injuries. So, you know, whether or not it can penetrate deep enough to make a difference with spinal cord injuries would probably be the question, but potentially even for positive benefits could be.
Okay. Actually, I do have an announcement about tomorrow's presentation, which was on the importance of early intervention. Unfortunately, the nurse that was going to be providing that is not feeling well, and so that is going to have to be rescheduled. So if you were going to join us tomorrow for the Medical Program Friends webinar, please know that that will be canceled and we will be rescheduling that. Once I have that date, I will send that information out to those people who have registered. And then we have debunking back pain, which is on the 25th, and Dr. Rue is going to do a great job with that. She's very excited about her industry, so I'm sure she'll be excellent to watch and learn from. All right, everybody, thank you very much, and we will see you next time. Thank you, ladies. Appreciate you.
Thank you.
And thank you, Angie. I know you're in the background.
Thank you. I am here. Thank you.
All right, bye-bye now.
Bye, Diane.